Hello students, today we will discuss about leukoplakia, a potentially malignant lesion. Leukoplakia is a frequently occurring potentially malignant lesion of the oral cavity. It is derived from Greek word leukos, which means white, and plakia meaning a patch. WHO World Health Organization defined leukoplakia being as a white patch or plaque that can be not be characterized clinically or pathologically as any other disease. As we can see in the figure that it involves the buccal part of the oral cavity, as we can see the white patch in the figure. The etiology of leukoplakia involves local factors, regional and systemic factors, and idiopathic leukoplakia. Local factors involve the consumption of the tobacco, alcohol consumption, chronic irritation, candidiasis, and electromagnetic reaction and galvanism. The regional and systemic factors involve syphilis, vitamin deficiency, virus, hormones, radiations, exposure, condition causing xerostomia, nutritional deficiency, and the intake of drugs leading to leukoplakia. Incidence, as it is depends on the geographical area with various kinds of tobacco uses. Uh, it is the ratio is 1.1 to 2.4 among men and 0.2 to 1.3 among women. Now in the pie chart, the chart given here, it is described the involvement of the sites in the oral cavity. The most common site involved is the buccal mucosa, 67%, tongue, then next is the retromolar area, alveolar ridge, then labial mucosa, and the least common is the palate site. Age and gender. The most common age at which the leukoplakia can be seen is 30 to 50 years, and the male to female ratio, it depends on the geographical distribution. As in India, it is more male predominance, seen commonly in males, but it's 1:1 in Western world. Now the different clinical types of the leukoplakia is the homogeneous leukoplakia. The homogeneous leukoplakia is a white lesion with uniform flat thin appearance that may exhibit shallow cracks and has a smooth wrinkled or corrugated surface with a constant texture throughout. Corrugated means wavy like folds or alternating furrows and ridges. Non-homogeneous leukoplakia has been defined as predominantly white or white and red lesion, uh, as known as erythroleukoplakia. They may be irregularly flat, nodular, or exuvitic. The nodular lesions are characterized by white patches or nodules on an erythematous base. Now, the homogeneous leukoplakia is uniformly flat, thin, as shallow cracks on the surface keratin. The non-homogeneous is involved in white and reddish appearance with irregular surface. Spectral leukoplakia is the mixed white and red but retaining the predominantly white character. Nodular leukoplakia, it has special character that it is seen small polypoid outgrowths, rounded red or white excrescences. Verrucous leukoplakia, it is a wrinkled or corrugated surface appearance. Proliferative verrucous leukoplakia, first described by Hansen, is a subtype of verrucous leukoplakia which is characterized by its an aggressive evolution. Actually, the proliferative verrucous leukoplakia is the progressive or aggressive evolution of the verrucous leukoplakia, as it is resistant to treatment. A multifocal appearance, high degree of reoccurrence is seen in the case of proliferative verrucous leukoplakia, and it has high chances of malignant transformation in oral caries as oral carcinoma. The candidal leukoplakia, it is an extremely chronic form of oral candidiasis seen as a firm white leathery plaques often found on the buccal mucosa, lips and tongue. The staining is of PAS staining is often used to differentiate it from other forms. Epithelial dysplasia is known to occur 4 to 5 times more frequently in Candida leukoplakia than in leukoplakia. Histology. In this histopathically, it is seen keratosis in upper layer, acanthosis with collocytes in middle layer, and the normal basal epithelium. Now these are the specific points you should know about leukoplakia, like architectural changes, cellular changes, and the abnormal variations. First, there are certain architectural changes are seen at the area of leukoplakia, irregular epithelial stratifications, and this is a specific character that the drop-shaped ridges are seen in case of leukoplakia, loss of polarity of basal cells, abnormal superficial mitosis is seen, premature keratinization in single cells, dyskeratosis which is known as seen, increased number of mitotic figures. There is an increased number of mitotic figures, keratin pearls within ridges, loss and the loss of epithelial cell cohesions. These points are must and very important to learn. That what were the features, specific features, the features are seen histopathologically in leukoplakia. The cellular changes are seen and the abnormal variations as in nuclear size. Anisonucleosis, which is known as abnormal variation in the nuclear shape, is seen, which is known as nuclear pleomorphism, and the abnormal variation in cell shape, which is known as cellular pleomorphism. Variation in cell shape, increase in or decrease in variation in nuclear size, and the nuclear shape variation, increased nuclear cytoplasmic ratio, abnormal variation in cell shape, anisocytosis, atypical mitotic figure, hyperchromasia, increased number and size of nucleoli. Diagnosis. One of the first and most important diagnosis is to clinically and visually examine the patch and to take an idea that it is a leukoplakia, differentiating from others like lichen planus, lichen planus, and other diseases. Clinical visual examination of oral mucosa is the first and most frequent method for oral screening the patch on the oral mucosa, followed by scraping it with a style gauge piece. Scraping the experience and skill of the clinician are very important in such screening procedures. But it is not only the method by which we can examine the risk of the level of the lesion. So combination diagnosis or the history and histopathology plays important role in the final diagnosis. The other methods are vital staining with toluidine blue, brush biopsy examination, autofluorescence. These are the adjuvatic screening aids, chemiluminescence, and biomarker assessment from saliva, serum, or exfoliated cells. In addition to this, there are numerous molecular markers at present, which there is no single marker or a set of markers which can reliably used to predict malignant transformation of oral leukoplakia in any one of the individual patient. Now, management of oral leukoplakia is upmost and most provisional clinical diagnosis. Estimation of possible cause in 2 to 4 weeks observation of the patient. Good response, then definable lesion, management accordingly. Then we can define the lesion and manage it properly. If no response, the treatment we are giving, if we find that no response, then definitive clinical diagnosis is done, biopsy, as or the no possible cause we can find of the disease leukoplakia, then biopsy is done. If there is a definable lesion we find, then management accordingly. If there is no definable lesion, dysplasia, identify it is dysplasia or no dysplasia, treatment of it is done, observation and follow up. Thank you. Please like, subscribe and share.